Hello and welcome, everyone. My name is Kristen Talbot. I am the program manager for the MAVEN project. Thank you all for joining us today, and our friends at Charles River Community Health Center for hosting today's session, How to Assess Cardiac Concerns in Children and Adolescents in Primary Care Clinics with Dr. Claude Rogé. Dr. Rogé completed his pediatric cardiology training at the University of California, San Francisco, and was hired by Kaiser Permanente Northern California. He remained on the clinical faculty at UCSF, eventually becoming a clinical professor of pediatrics. After retiring from Kaiser, he became the medical director for school health clinics of Santa Clara County and FQHC, serving the underserved population in Santa Clara County, California. In addition to his administrative role, Dr. Rogé still sees children presenting with the most common cardiac conditions in his clinic and reads EKGs. And we're just so very lucky to have him as a MAVEN project volunteer. So Dr. Rogé, when you're ready, please begin.
Yes, good afternoon, everyone. Can you hear me okay, Christine?
Yes, you're good to go.
Very good. Yeah, good afternoon, and let's start. And, again, please ask any questions so we can, he doesn't want to move forward here. What's going on? Okay, there we go. All right, so a few disclosures here. We go fast towards that. So, basically, these are some of the points. Of course, family history is very important. History of events surrounding the apparition of symptoms. Of course, we go over some aspect of what's important when you do a cardiac physical evaluation. And then when you order appropriate tests, what type of test, and when, especially if you are federally qualified health clinics, when do you refer to pediatric cardiology? So we go over all that. So Christine already told you this. So this is what we're going to talk about. Little introduction, then we will go over sports physicals, and then we will go over the cardiac evaluation for primary care providers during the routine work in the clinic. And so we'll focus on evaluating patients with heart murmur, patients with hypertension, and then spend a little time, if we have time, on evaluation of symptomatic patients. So, obviously, primary care clinicians have an essential role in the detection of heart disease in children. And so the goal of this introduction is to make a primary care provider better equipped to evaluate the child. So when is the PCP in the role of detecting heart disease in children? Again, when doing sports physical, and when the PCP detects a heart murmur or hypertension during a routine visit, or when evaluating a child with cardiac symptoms. So let's talk first about sports physical. Pre-participation physicals are mandated in nearly every organized athletic program and are performed with the intent of identifying any condition that may preclude an athlete from safely participating in athletic events. And so I'm going to go over what we call the pre-physical evaluation, pre-participation physical evaluation. And you probably are using a version of that when you see patients. I don't know how it works where you are. Sometimes the school will provide a form that you need to complete, or you provide a form from your clinic. And usually this will be a PPE that was developed by these organizations that are involved in pre-participation physical evaluation. So American Academy of Family Physicians, American Academy of Pediatrics, College of Sports Medicine, et cetera, et cetera. So all these organizations that participates in sports medicine, let's call it that way, contribute to that sports physical pre-participation form. Now, this is the one provided by the American Academy of Pediatrics, and there are two forms. you have first the history form that's completed by the patients or the family, and that's available in English and Spanish. And then you have the physical examination that is completed by the provider. Now, in the history form, you can see there are questions that are very important, and you can use those questions when you evaluate patients with symptoms as well. And you can see these are looking for red flags. So have you ever passed out or near passed out during or after exercise? The same for chest pain. Do you have any discomfort, pain, tightness, or pressure in your chest during exercise? The same is for palpitations. Does your heart ever race, flutter in your chest, skip beats during exercise? The same is for syncope or near syncope. Do you get lightheaded, feel shorter of breath than your friend during exercise? So again, remember those questions. Any time you see a child in the clinic with symptoms, you ask if they occur during exercise, and that will be always a red flag. You need to worry more if they occur only during exercise. And then there are other questions, especially family history, early cardiac death in the family, and then the genetic heart problem. Now, some of these things people are not going to know what you are talking about unless a family member is affected. The most frequent one is hypertrophic cardiomyopathy. That's 1 in 500 people. So that's fairly frequent. So that probably is the most, and also is one of the most dangerous one, potentially causing early cardiac death. Then Marfan syndrome, all the other ones are going to be much less frequent, but it's something you need to look at. And again, that's going to be kind of weird names for most people: Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia. But if their father or grandfather had that, maybe they would be aware of that. And then, of course, you have on the history form kind of a review of system of all the different organs. And then on the physical exam form, there is a loss of focus on the appearance, because that's the way you will suspect Marfan syndrome. Kyphoscoliosis is bending of the spine in both directions, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity, the thumb sign, where in most people you cannot go past the line here, but with Marfan syndrome, they can go past that way. So all those things would suggest a possibility of Marfan syndrome. And of course, you are going to focus on the heart, not only auscultation, but here is very important. We go over that again. When you listen to a patient, it's very important to do it in the supine and then in the standing position. And we'll go in more details about that. Okay. So the focus of the provider is to rule out the rare cardiac conditions that can cause sudden cardiac death during exercise. So let's review that a little bit. This is, again, a rare event, okay? If you compare the cause of death in children, and adolescents, sudden cardiac death is not very frequent, as you can see, 50 here, when, for instance, twice as likely you die from lightning, falling from home, fires, from firearms is 10 times greater risk. You see drowning, much more common. And of course, motor vehicle accidents. So there are rare events, but you want to hopefully detect it, who is at risk. So they are active, but in a safe way, okay? So again, this is putting back in perspective, heart disease in children and adolescents is not a very common cause of death, if you see all of the other much more common cause of death here in children and adolescents. Now, what are the cause of sudden death in competitive athletes? Well, the biggest one, about 50%, is hypertrophic cardiomyopathy. So it's something that you are going to really make sure that you don't have any reason to suspect that. The next one is going to be coronary artery abnormalities. Now, if you take care of only of children and teenagers, it's going to be the coronary artery anomalies, some congenital misplacement of the coronary arteries, abnormal course, that type of thing. But if you take care of young adults, you are going to see more and more coronary artery disease. And the third one is the rupture aorta, and that's where the MAVEN syndrome and other connective tissue disorders fit in. Okay, so these are the three most common: hypertrophic cardiomyopathy, coronary artery abnormalities or disease, and rupture aorta. So, as a primary care provider, how do you suspect this condition and prevent sudden death? Well, let's talk about hypertrophic cardiomyopathy a little bit. Normally the sarcomere is very well organized. Like it is a schematic picture here of the way it looks. You have the thick filament and the thin filament, and they intertwine on a very regular basis. So this is the way it looks with a microscope. And in hypertrophic cardiomyopathy, you can see it's characterized by multiple pathological features, but you have myocyte hypertrophy, disarray, and interstitial fibrosis. So that's really affecting the way the muscle works. So let's talk about it a little bit. It is an autosomal dominant. Okay. So the problem with that, usually a first-degree relative is going to have it, but the expression of, even if you have the gene, varies tremendously. You can have people who die suddenly in their 20s, and people who are asymptomatic, and they go for in their 70s or 80s, they go for elective surgery for a prostate issue, and the anesthesiologist wants to make sure everything is okay. He gets an electrocardiogram, and oops, the electrocardiogram is abnormal. He gets an echo, and that patient who was asymptomatic all his life has hypertrophic cardiomyopathy. So there is very valuable penetrance. So of course, if sudden death, unexplained sudden death, or someone who is diagnosed, of course, is going to be easy, but you are going to miss some patients, even though a first-degree relative is affected. It may not be obvious. So again, going over the incidence of hypertrophic cardiomyopathy, as you can see, is quite frequent, more frequent than Down syndrome. So if you see kids with Down syndrome in your practice, you should have as many as patients with hypertrophic cardiomyopathy, but it's not as obvious as Down syndrome, of course. And you can see the other ones are much less frequent. And again, what it does is that it involves usually mainly the left ventricle is mostly affected, and most of the time the septum is especially affected. So you have a very thick septum. So how do you suspect that, aside from the family history? The symptoms, again, as we mentioned before, if someone has chest pain, palpitations, or fainting with exercise, that should raise a suspicion for you and look into it a little more. Now, in terms of the physical exam, this is where the auscultation is very important. And we will go over this again. Most innocent murmurs are going to be louder in the supine position when people are lying down. In hypertrophic cardiomyopathy, it is the other way around, okay? So when people stand up, suddenly the murmur becomes louder. So it's something to remember. Every time you hear a murmur in children, always listen the patient lying down, patient sitting up, and the patient standing up. Innocent murmurs are going to be softer when people stand up. Hypertrophic cardiomyopathy, they are going to be louder, okay? So if you see a child with murmur is louder in the sitting or standing position, always get an electrocardiogram. In hypertrophic cardiomyopathy, usually it's going to be abnormal. There is an example here, very big Q waves that you see in the left precordial leads, here inferior leads as well. So that, will be always a first step. It's something you can do in the clinic. The second most common cause is the coronary artery abnormalities. So in children, it's mainly going to be abnormal connections of the coronary artery. This is a normal ways, left coronary artery from the left coronary sinus, and the right coronary arteries from the right coronary sinus. And you see the left circumflex coming off here, the left anterior descending aorta. So you see there are multiple variations of origin of the coronary arteries, of course of the coronary arteries, like sometimes the left coronary artery going between the pulmonary artery and the aorta, you're getting squeezed. So again, that will be often also chest pain with exercise would be a symptom to worry about. More rare in children, it will be acquired, but if you see young adults presenting for sports physical, is something to consider. Atherosclerosis is going to be possible, but also to keep in mind that it can also be sometimes drug-induced. That was a study here where, actually a number of drugs can cause that. So you may want to consider that, asking that type of question if people are taking any drugs. Okay, the next one. So how do you suspect this condition? Of course, if it is from atherosclerosis, you may have a family history of coronary artery disease. And then if it, again, chest pain or syncope with exercise will always be a red flag. And again, abnormal ECG. And then if you suspect that there may be people taking drugs, then definitely you may want to get a drug screening. Now the troponin, I would get this only if people say, oh yeah, this morning I had terrible chest pain when I was running. You may want to get it there. Otherwise, if it has happened like weeks ago, there is no point in doing that. Lipid panel is never a bad idea to get, okay? And some of the, in that article I mentioned here, these are some of the substances that can actually cause some coronary artery spasm. So, something to ask if it is a young adult. Okay. The next one, most common one, is rupture aorta. And the most common cause for that is going to be connective tissue disorders and MAVEN syndrome again, kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity, myopia, mitral valve prolapse that you will hear, like a mid-systolic click, and then maybe a mitral valve regurg. So the MAVEN would be the most common. Other one would be less common, Ehlers-Danlos, Dietz syndrome, Turner. But there are other causes of aortic root dilatation. Bicuspid aortic valve, that's a very common condition, but usually, and it causes aortic root dilatation, but usually not to a level that would cause rupture in children and young adults, usually it would take decades before the aortic root is really dilated to that point. And atherosclerosis, of course, is another cause of rupture aorta, but that's going to be very rare in children. Um, uh, and again, you will have a family history of early cardiac death and hyperlipidemia. So, in conclusion, for sports physical, always use that PPE is recommended. Again, if the patient has symptoms with exercise or any suspicious clinical finding, like a heart murmur, louder in standing position, the Marfan's phenotype, then before you give the green light for sports participation, make sure you get further cardiac evaluation. So next, we are going to be in the situation when the PCP detects a heart murmur or hypertension, okay? So this is a case here. Juan is a 5-year-old healthy boy. You have been following him since birth. But for the first time, when you hear a grade 2/6 musical systolic ejection murmur at the left sternal border in the supine position. So what do you do next? Oh, there are a few chats here. Should we see what's going on in the chat?
There is one question. It says, are some ADHD meds a risk for coronary artery spasm and ischemia?
Well, if someone has an underlying, I mean, for most people, I would say no. But if someone has one of those underlying conditions that we talk about, uh, probably that would increase the risk. Yes, yes. So yeah, I mean, you may want to be careful before prescribing this medicine. Going through that same thinking and ruling out underlying heart disease. That's a good idea. Yeah, yeah. So on my here, usually I can make it listen, but I don't think it works. Oh, actually, I'm not able to move the slides here. What's going on, Kristen? It is,
Let's see. If you can put your cursor towards the left corner, the bottom left corner, and then the
oh,
arrow.
okay. All right. So I hope I didn't. Yeah, okay. All right. So um, now you review the family history. There is no history of cardiac disease. That's good. You review the past medical history. No cardiac symptoms, normal growth. So then you do a physical exam. You did it before, but you are going to, now that you hear the murmur, you are going to repeat that very carefully, okay? So you check the capillary refill, perfect, no evidence of cyanosis. The saturation, again, you do it 98%, great. You take the pulse in all extremities, good. Strong pulse, no radial femoral delay. And you take the blood pressures, okay, in the arm, the right arm is fine, the right leg, you take it, good. It is a little higher than in the arm. That's what you like to see. A little higher systolic, lower diastolic, that's perfect. Then you repeat the auscultation and you normal S1, split S2 is heard at the base, and you hear that only during inspiration. That's also a good sign. And you listen carefully for extra sounds, but you do not hear a click. You do not hear an S3 and S4. And you listen again to the heart murmur carefully, and yeah, it sounds like a twanging sound, like playing with a string. And it is louder in the supine position, the left sternal border, and harder to hear in the sitting and standing position. So the murmur is not transmitted to the neck, the axilla, or the back. Diastole is clear. Lung auscultation is normal. There is no organomegaly. You even ask your MA to check a hemoglobin, and hopefully you can do that in the clinic, and it is normal. So what do you do next? Okay. I could ask and see what people say in the chat. um, I would ask that question again to see, so you can think about it. But one thing you may want to do, and that you would do that very quickly in your mind. You will not have time to sit down, take off your clothes, and spend hours thinking about it. But what go to your mind? Am I missing a heart defect here? And so this is a question that probably pops up in your mind. And I put a study here that's from the Atlanta area. See the prevalence of congenital heart disease. And in green, I put the one that you, primary care providers, are going to be more likely to actually detect. The other one that are in darker, um, most likely they would have been picked up in utero or at birth. Okay, so tetralogy of Fallot, hypoplastic left heart syndrome, single ventricle. But the one in green, you are the one you are going to have to suspect it. Now, ventricular septal defect, that's the most common. And do you know why it's not detected in utero or at birth? I mean, if we were in person, I will ask you and you would tell me. But um, again, I don't know if anyone wants to, to talk or say the answer. But probably I give you the answer. Well, the problem, if you do a fetal echocardiogram or obstetrical ultrasound and you are looking for a left to right shunt, you are not going to see that in the fetus because the pressures in the right ventricle and in the left ventricle are the same. So you are not going to see the shunt. So unless it is kind of an obvious defect, uh, that cause a malalignment of the arteries or something like that, you are not going to see that before birth. And it is the same in the nursery. It takes a while for the PA pressure to drop, and especially if the VSD is fairly large, it may take actually weeks or months before the left to right shunt takes place. So that but the murmur of VSD usually typically is going to be a harsh murmur and is going to be a pansystolic murmur. And if it is a patient you have been seeing since birth, most likely you will start hearing this after a few weeks, after a few months, but not for the first time at 5 years of age. So you can relax. No, that I'm not missing a VSD here. Now, ASD is a little more complicated because ASD, the murmur is going to be much softer. Um, the murmur, but the murmur usually is going to be at the base, not at the left lower sternal border. And the murmur usually is going to be at the base. And then there is a typical finding. It is S2. You hear the splitting and it is a fixed splitting. So very important to listen to S2 carefully, put the patients in a supine position, in a sitting position, and see if you see variation in the splitting with respiration. In ASD, it would be a fixed splitting. So murmur at the base, fixed splitting of the second heart sound, but you don't hear this on that child. Okay. Now, PS, murmur is going to be in the same area. It is going to be at the upper sternal border, and often you are going to hear it in the axilla and in the back. And often in pulmonary stenosis, you are going to hear a systolic ejection click. And you will hear that usually, along the left sternal border. So again, in that patient, you don't hear a click, you don't hear the murmur going in the back, you don't worry about that. Coarctation is very important to always make sure, am I missing a coarctation here? Okay, so the way you do that is very simple. You take the pulse at the same time in the arm and in the leg. And you want to make sure you feel a strong, in young children, the femoral pulse is always the best one to take. You take a strong femoral pulse, and there is no delay between the radial pulse and the femoral pulse. Very important. Now, the PDA, again, may not show up. Again, it's normal to have this at birth. It's normal to have it for a few days. But a PDA, again, most people, you will start hearing it sooner. And what's typical about a PDA murmur is that it is a continuous murmur. It's not only a systolic ejection murmur. And it's not really usually at the left lower sternal border. It's going to be, mainly at the base, and you will hear in the left axilla in the back, continuous murmur. Now, AS, aortic stenosis, again, is going to be systolic ejection murmur, louder at the base, not long sternal border or at the apex. And that murmur is going to go into the neck. So always when you hear a murmur, you listen carefully at the base and in the neck. If you hear a murmur, transmitted to the neck, it's a little of a red flag. If you hear a click, definitely, so you would need to evaluate that child more. Okay. So, again, I'm asking the same question, and you want to put in the chat. I'm curious to know, what do you do next? You have gone through all this. This is your regular patient. So you have three choices here. You reassure the child and the parents. One has a normal heart sound. We often hear it in healthy children. We call it innocent heart murmur. So that's answer number one. Option number two, you order an ECG. And option number three, you refer to pediatric cardiology for further evaluation. So I'm curious to know what you already are doing, and after that discussion of that case, what will you be doing? You may want to put the answer in the chat, and Christine is going to follow that and let me know what the answers are.
So far, we have ECG and echo, then the number 2, and then maybe CXR.
What was the last one?
It's maybe CXR, and then somebody else said number 1.
Okay. Well, I want to tell you, there is not one good answer, okay? It all depends on how comfortable you are in doing that evaluation, okay? But if you are comfortable, the best answer is number 1, okay? Because again, 80% of children have heart murmurs. You are going to hear, not all the time, but over, if you see a child for whole childhood, okay, 80% of the time, you at one point, you are going to hear a murmur. So if you refer every patient to cardiology, that's good business for the cardiologist, but it is also lots of annoyance for the family, transportation, lots of anxiety waiting for the, having to worry about, what's going to happen and all that. So if you are comfortable, and if you have done a very thorough evaluation, number 1 is the best choice. Now, number 2 is not a bad choice, okay? Because number 2 will help you detect things like hypertrophic cardiomyopathy. The murmur occasionally in hypertrophic cardiomyopathy is not that typical, and so it will help you with that. The problem with number 2 is that you have loss of false positive ECG in pediatrics, okay? So if you do it in every child with a heart murmur, you are going to have loss of false positive, generating loss of anxiety. And of course, we need further evaluation. So that's a negative. Now, refer to pediatric cardiology, of course, there is nothing wrong with that, but it's loss of inconvenience for the family. I mean, it depends where you practice and how easy it is to get a pediatric cardiology. But I know, in some areas, transportation, waiting time, and in the meantime, what goes through people's mind is a lot. So, I'm not saying there is one perfect answer, but It depends, again, how comfortable you are with evaluating a child. If you can do number one, that's the best. Number two is not bad, but there are side effects because there are so many false positives. And okay, three is the safest, of course, but loss of anxiety with that. Okay, so let's say you did number one. Okay, well, there is a summary here. Most children have a heart murmur heard at some time during their childhood. A very small percentage have a heart problem. Most of them have innocent heart murmur. So they are, okay. So again, we are talking about people with heart problems is about maybe at the most 1 or 2%. Heart murmur, 80% of children. So, there is a big difference. So again, there are several types of innocent heart murmurs in children. Stealth murmur is the one we discussed, pulmonary flow murmur, systemic flow murmur, venous hums. So ideally, the primary care provider is comfortable after a thorough clinical evaluation, making the diagnosis of innocent heart murmur and reassuring the parents. In that case, the electrocardiogram is not indicated. False positive increase the anxiety of family, and we require a referral to pediatric cardiologist. Level of comfort of primary care provider depends on training and hearing capacity. Yeah, I want to stress that. I mean, I practiced with lots of excellent pediatricians, and I saw a whole spectrum. You had fantastic pediatricians, but they did not have very good hearing. They had to refer every patient to me, okay? And you had some other pediatricians who were not that great overall, but they were fantastic figuring out if it was a normal murmur or not. So, there is lots of variation there, okay? But eventually the goal is to be reassuring the parents. But that can be a challenge, okay? That can be a challenge because this is what goes through the mind of a mother after you tell the child, oh, don't worry, your child has an innocent heart murmur. This is what goes through the mind of the mother right away. Half of them say, oh, it's going to need medications. 40% is going to be restricted from sports. He loves to play football. A third say, okay, he's going to need cardiac surgery. Or the other kids are going to be affected too, okay, because that runs in families. Okay, of course, some people are going to blame themselves. So, why is there so much anxiety? Well, of course, how most people have a parent who has died of heart disease, because let's not forget, heart disease is the #1 cause of death. So the other thing is that, of course, the media always reports a very rare case of sudden death in young athletes. So people are aware of that. This is why, uh, they are worried that something is going to happen to their child. But also, let's not forget, the heart is the most important organ in the body. Now, this is not only what cardiologists believe, but if you go over, if we go back to ancient Egypt, we all come from Africa, according to what people say, our ancestors came from that. Well, this is what they thought in Egypt, that, um, after you die, you have to go through the hall of Maat, and there is a god. He takes your heart and he puts it on the scale, and on the other side he puts a feather. Okay, and if your heart is as light as a feather, you make it into your afterlife. Otherwise, you go to hell, right? And so you are eaten here by that god here is waiting for you. So very important hearts in ancient Egypt. Of course, you heard in the Aztec culture that the heart not only belonged to individual, but it also belongs to the sun gods. And in order to thank the sun gods, I mean, the sun gods, they sacrifice themselves all the time to fight against darkness so man can survive. So once in a while, you have to give an offering, and the best offering is actually a beating heart. So you get it from someone going through the abdomen, the diaphragm, and you offer beating to the sun gods. By the way, this is not a sun god, but I like that. This is another god, it's full of colors, so I put it there. And this is not accepted anymore. But if you go from Quebec to Chile, you see that the heart is still very important. It people are reminded there all the time that it is a very special organ. And then, if you go around the world, the heart is the organ where essential human emotions and virtue resides. And there's a few examples here, India, Europe, etc. Okay, so let's go to case number 2 now. I don't want to run out of time. So this is now an 8-year-old boy, and is scheduled for a routine well-child physical with you. And Arthur has been followed by a colleague of yours. You review the chart and you see that he is overweight, has mild hypertension, and had normal laboratory results, lipid panel, and renal function. Your colleagues refer the patient to a pediatric nephrologist, and he diagnosed mild primary hypertension related to overweight. So what do you want to document on this physical exam? And I briefly mentioned it before on the previous discussion. Anyone, what's really important to document here? Anyone wants to write it down or talk about it? Someone did.
We have
They said,
hypertension and weight.
right, in the legs, right? Excuse me, Christine, what did you say?
It says, oh goodness, hypertension and weight is just the only comment I see.
Oh, hypertension and weight. Yeah, that's right. It is often connected, and that's what the nephrologist, probably he was in a hurry, and that's a typical thing. Oh yeah, he's overweight, he's a little hypertensive, that's typical. But you, as a primary care provider, you need to do something different than just come to a conclusion like that. I briefly mentioned it to you. What do you want to do? Okay, well, I would say that that's what you want to do. You want to always measure blood pressure in 4 extremities, okay? So if you remember one thing, if you have any child with hypertension in your clinic, always take the blood pressure in 4 extremities, okay? You tell your MA, please take the blood pressure in 4 extremities and write it down for me, okay? And this is what you have here. And what do you see? In the upper extremities, it is higher than the lower extremities. Is that normal? No, it is the other way around. Normally, it's higher in the legs than in the arms. So remember that. Anyone with hypertension, always take the blood pressure in the legs. Now, you listen to the patient, you also happen to hear a murmur at the base, in the axilla, and in the back. So, can I ask you what you suspect now?
Don't aortic coarctation.
Correct. Okay. All right, very good. This is what you need to always think about. Anyone with hypertension, you don't want to let him go out of the door until you take the blood pressure in 4 extremities, okay? It's very important. So you suspect, very good, coarctation of the aorta. And so what do you do next? You order an EKG and a chest x-ray. The ECG is normal. The chest x-ray most likely is going to be normal, but people who have severe coarctation, it can be slightly abnormal. You may show here rib notching, and you may show the 3 sign here. You see the picture here of the angiogram, the artery, and on the side it may make it looks like a 3. But most of the time it's going to be normal. And in that case, there is no argument. If you have gone that far, hypertension, take the blood pressure in the arms and the legs is higher in the arms and the legs, for sure you are going to refer to pediatric cardiologist. Okay. And then you would do an echocardiogram, and then the echocardiogram, you can see the ascending aorta going around, and then you can see a narrowing here. And then when you do the color Doppler, blue will be the normal way it is, and then you get that bright color here from the increased velocity in that area. Now, the MRI, you wouldn't be ordering that, and that would be the pediatric cardiologist deciding if they do an MRI or not. It depends where you are, how it is treated. If it is treated with surgery, they may want to get an MRI because that's where you can see the collaterals very well. You see the coact, also the narrowing on the aorta, but you see all the collaterals vessel. That's important. If it is going to be treated in the cath lab, then it's probably not necessary. They would just do a cardiac cath. And here on the angiogram, you see the narrowing on the artery. And this can be treated either with a stent in the cath lab or with surgery. And that gives you a scar. So coarctation of the aorta is not very common. But again, this is your role as a PCP is to detect those early if you can, okay? So again, we're all going over it, abnormal pulses. So always important to feel the pulse in both arms, then one arm and one leg at the same time, looking for radial femoral delay. And then any patient with systolic hypertension, you always measure in arms and legs. So, and then the ejection murmur, and then they will have a click if there is a bicuspid aortic valve. Often there will be an association of coarctation in bicuspid aortic valve. And again, the message here is anytime you have a hypertensive patient, always rule out coarctation of the aorta. So it's one thing you may want to remember, okay? Always take the pulse in both arms at the same time, then take the pulse in the wrist with a stronger pulse and in the lower extremity at the same time, looking for radial femoral delay. And then you take the blood pressure in two arms and in one leg, okay? So this is what to remember. Okay. All right, we have 10 minutes, so let's quickly go over how do I manage a child presenting with symptoms? Okay.
Dr. Rogé, there is a quick question.
Good.
How do you assess bradycardia in an athletic adolescent with anorexia and significant weight loss? Is it safe to exercise?
Okay. It depends how extreme the anorexia and the weight loss is. And, again, if it is mild, anorexia, exercise is good, but if it is extreme, you will coordinate that with the specialist. If it is extreme, you are going to talk to someone who specializes in that, and you will coordinate the timing with them. But in the extreme cases, no. If it is very mild, you suspect someone is losing some weight, some change in behavior and things like that. Balanced diet and exercise mild exercise is not a bad idea. But again, I leave it to you to decide when it is into the dangerous level here. If you have someone with extreme bradycardia, loss of, the weight is way below, the third percentile and all that, you are going to be on the cautious side for sure. Yeah. Okay. All right. So most children and adolescents who are presenting in your clinic with symptoms of chest pain, palpitation, or syncope are going to have a non-cardiac cause. For instance, if you take, there was a study looking at all the kids presenting to the emergency room for chest pain, and about 4% had a cardiac problem. So it is really the exception, but it is always a red flag. So you want to explore that very well before you authorize to do sports. So again, we talk about it a little bit when we did the sports physical, but you are going to ask a bunch of questions, and then you will put the patient into one or two categories. If he has normal growth and development, that was, referring there to the anorexia, that's going to be a red flag. You're going to be careful there. You ask if there are any symptoms with exercise, family history of heart disease, and again, with the symptoms, if they occur um, with exercise, that's always a red flag. But symptoms suggest a non-cardiac cause like chest pain after eating, syncope after sudden cardiac change, position, palpitations during stress only, not with exercise. That's probably okay. Normal physical, and then you may do some screening tests that you can do in a clinic, EKG, maybe chest X-ray only if needed. Then you can reassure the patient and follow in the clinic. But again, if you find any symptoms with exercise, if you have any family history of heart disease, of sudden death, or if you have any suspicious cardiac findings on physical exam, or if you have an abnormal ECG, then that is definitely when more testing is needed, and you may want to do a referral there for further evaluation. Okay, in conclusion, most children who have a heart murmur have, as you know, have an innocent heart murmur. Again, 80% of kids are going to have a murmur, and only, less than 2% are going to have a heart problem. And so most children who have a heart murmur have no structural congenital heart defect. The same is true for palpitations. As you know from experience, most children with palpitations usually it's going to be from anxiety and a normal heart. Again, if the palpitations occurs only with exercise, that's a big red flag. Chest pain, again, most kids with chest pain, we saw only 4% of them are going to have a cardiac problem. But again, if it is chest pain with exercise, big red flag. Always ask if there is a family history of heart disease. Syncope, again, it depends how it occurs. If it is like a quick standing up, it's not as worrisome that if it occurs after the child has been exercising for a while. Okay. So before, as a primary care provider, you come to the conclusion that the child has a normal heart, you want to explore carefully and make sure you are not missing a cardiac diagnosis. Okay, so these are the reference, and I guess we have 5 minutes. We are open for more questions.
Thanks, Dr. Rogé. Fantastic as always. If you have any questions, please put them in the Q&A box or use the raise hand feature and I will unmute you so you can speak directly to Dr. Rogé. I always recommend this for big words. I usually stumble over them. But just a reminder, while we're waiting for those questions, that when you X out of this webinar, the CME survey is going to appear. If you complete that with the email address that's affiliated with your MAVEN project account or the email address that you registered with, the correct licensure, correct date, June 26th, and the correct speaker, Dr. Rogé, you'll get your certificate almost immediately. But if something is wrong, I will fix it eventually, and you'll get your certificate. I still don't see any questions. Don't worry, I can ramble for a while while we're waiting. Reminder that if you think of questions after this section, I always do, you can always go onto the community portal and submit an e-consult directly to Dr. Rogé or any of our MAVEN project volunteers. You'll have a response in less than 48 hours.
Don't hesitate to do that. Sending questions by on the MAVEN project. We have two pediatric cardiologists. Dr. Engoff is in the East Coast. I am on the West Coast. And, we are happy to help you with any case that you may have. Yeah.
All right. We do have a quick question. There we go. Could you tell us a bit on how to recognize benign chest pain syndromes, for example, precordial catch syndrome?
Yeah. Well, the precordial catch is probably one of the easiest because often you need to do palpations of the ribs and the sternocostal junction here. And most of the time, you may simulate a little pain when you do that. So, that's a good thing to include into anyone presenting to your clinic complaining of chest pain. You may always want to do I did not mention that, but palpations of the chest, you follow the ribs, you go all the way to the sternum, and that's going to be a very common cause. Pre-glottal catch syndrome is similar to that. So that's going to be a common thing. So if it is positive when you press on the ribs or the sternum, that's usually, I mean, it still hurts, but it is a good sign in terms of it's less likely to be a heart problem, right? I mean, I saw chest pain being from a heart problem, mainly if it happens with exercise, then of course you are going to think about that and get an EKG and all that. I mean, um, again, you may want to get X-ray also. Problem with that is radiation, and most of the time it's going to be normal. But if you have any doubts, you can always get a chest X-ray also. Yeah, for chest pain. There's another question,
Yes.
Kristen.
Teenagers often pass out during blood draw. How to reassure a parent? I also pass out during blood draw, so any tips would be great.
I'm not sure what the question is. So what happened there?
How to reassure a parent. So teenagers often pass out during blood draw. How would you reassure a parent? I'm not sure this is your wheelhouse.
You mean like if you send him to the lab to have blood drawn? That's what they are talking about?
I think so. I don't know,
Yeah,
Judith.
I mean, it is, you do your best to reassure people. I mean, I'm not a specialist in psychotherapy, but you try to make them relax and think about something fun and that type of thing. And but for young kids, it can definitely be a challenge. Yeah, uh, but it mainly is going to be in teenagers, and older kids when you order a blood test. And yeah, I mean, anxiety is a problem, and uh, maybe they need some help before, if you know it is a very anxious patient, maybe they need some help before they go to the lab. You cannot send everyone for help before they go to the lab, but the people who are really very anxious in your practice, yeah.
I have to lay down when I get blood drawn, so I understand.
Yeah, no, it can be a challenge, yeah.
It's my brain. Well, I don't see any other questions. So,
Okay,
oh,
very good.
wait. Oh, sorry. Maybe oh boy, big words. Maybe a vasovagal response that could respond to vasovagal counterpressure measures.
Vasovagal, yes.
No.
Vasovagal, that often, is going to be an explanation for like syncope and things like that. And so that, so often people would get more symptoms with quick change in position and things like that. Um, I mean, you start with the basics there. If you suspect that, increase fluid intake, increase maybe if it's safe, there's no other issues. Sodium intake. You don't want to recommend that to all your patients, increase sodium, but people who have some vasovagal symptoms like that, yeah, drinking more, maybe taking a little extra salt, and of course you want to take the blood pressure when they are lying and when they are standing, and you see if there is any big difference there. Yeah, but that's more for the syncope type of symptoms more than the chest pain. Yeah, yeah.
Wonderful. All
All
right,
right.
Dr. Rogé, thank you so much, and
Yeah,
thank you all for joining us today.
yeah. Have a nice afternoon and goodbye.
Thanks.
Bye-bye, Kristen.